Hi everyone, can you hear me? Welcome, thanks for being here, for joining us tonight. My name is Sylvia Solis. I am the Colorado News Collaborative Community Engagement Director. And I just want to give you a warm welcome. Thank you for making some time out of your evening to listen to this important conversation. I'm just going to give you a few instructions, and then our Executive Director, Laura Frank, is going to give a more thorough introduction. So we're going to hear from our panelists. We're going to have some time for some community questions from, the online platform, as well as live questions from you. The way that I would like that to work is if you grabbed a note card and a pen, you can just note those down, write those down, and then I'll come collect them. If not, we're going to be doing something a little different. You can text them to me. That might be easier for some of you. So I'll just give you sort of the number now that you can text your questions to, and I will be feeding those to our moderator, Susan Green. So that's 303-564-9240. All right, okay. And so without further ado, Laura, please.
Thank you, Sylvia. Thank you, everyone, for being here, to our panel and to our audience here in studio at the Buell Public Media Center and at home watching the stream over YouTube. I'm Laura Frank. I am the Executive Director of COLab, which is the Colorado News Collaborative. We're a consortium of more than 170 news outlets across the state, and we got our start about the same time as the pandemic. So we've been around for 2 years. We are more pleasant than the pandemic then. We started with a number of partners really talking about issues of mental health and concern about the system and what people in their communities were facing. And so about the time we started, we also launched something called On Edge, which is a series of investigations and stories that started looking at the way that Coloradans were coping, not only with the pandemic, but some of the other social stressors that have been going on over the last 2 years. That moved into phase 2 of On Edge, which was an investigation that Susan helped lead across the network of media. And I want to highlight some of the findings of that. It really started with the statistic that Colorado has one of the lowest rates of access to mental health of any state in the country. And Susan and the reporters wanted to find out why that was. And they began looking at the mental health safety net system, specifically the 17 regional community mental health centers across the state. And they're not a very easy thing to cover because though they really use mostly tax dollars, they are individual, private, nonprofit corporations, and they don't really have to reveal a lot of information. But the findings that came out of that set the table for the discussion that we're going to have here tonight. Some of those centers were turning away some of Colorado's most vulnerable citizens in crisis. They were collectively treating fewer clients during the first year of the pandemic than they had in the previous before times. You remember those. The state inadvertently created financial incentive for the centers to see fewer ill people and charge more, but really didn't introduce competition into the system. And they've been charging taxpayers up to 17 times more than independent Medicaid providers were charging for the same services. Finally, the reporters took a look at the center's trade association that had, as it turns out, a record of influencing the state to avoid reforms that might have brought some transparency and accountability to the system. So it's part of COLab's mission to report stories that are really complicated like this, that many newsrooms might not be able to do on their own. And so that's where the collaboration comes in, and you're going to hear more about that. So what we're in right now is kind of phase 3 of this collaborative project. And in my view, we're really taking the collaborative journalism to a new level. We've amassed a small team of investigative journalists from what you might consider previously balkanized news outlets who were mostly competitive with each other, now are working together to take a look at these issues about the mental health safety net system. People like Jennifer Brown at the Colorado Sun, who's been reporting about an unprecedented shortage of behavioral health professionals. Chris Osher from the Colorado Springs Gazette, who with Susan's help has revealed deadly prescription errors that went unchecked, and Ben Marcus here on the panel tonight, who looked at a previously failed attempt at reform and how political connections maintain the status quo in that case. There are more documents, more data, more tips being unearthed by this team each week, so you can expect more reporting to come on this. But please let me introduce our moderator tonight, Susan Green, who you may recognize her as a former Denver Post reporter and columnist. She was the editor and executive director of the Colorado Independent, and her work's been a finalist for the Pulitzer Prize for Investigative Reporting. She now coaches journalists across the state to do what she does so well. So thank you for leading this important conversation, and panelists, thank you again, all of you, for being here.
Thank you, Laura. Thank you, Sylvia. Hello, everyone who here in person, out there in digital land. I just want to say, for most reporters, the last couple of years have been very disembodied. We've been doing more work than ever by phone, which none of us really like to do so much, and by Zoom. So just being here in our new office building and in this new studio is a joy. And so thank you for joining us and for your interest in an issue that really spans political divides, rural-urban divides, racial divides, generational divides, that we're pretty sure have not gotten enough attention in this state. And so here we are doing this, and it's been my great privilege to be able to work on this project. Hello, people on the couch. I promised myself I would not make that pun. Talking about mental health, I am going to ask you each to introduce yourselves. You are all mic'd up, right? And please just briefly introduce yourself and say, what your connection is to this whole age of reform. And yeah.
You're looking at me, so you want me to go first?
I want you to go. Sorry, I want you to go. They all have those fancy little things, but I have to use the microphone. I want you to go in that order and just take about a minute doing so, please.
Okay. Hi, everyone. I'm Tamara Pogue. I'm a Summit County Commissioner. Prior to being a commissioner, I ran a family resource center for a decade, and that's where I first got a up-close and personal glimpse of the folks that this system is failing. And so I decided to run for commissioner, actually because of this issue, because in Summit County, we've passed a mill levy to support behavioral health. We have diversified the providers in our community. We've done pretty much everything we can to take better care of folks in our community. But ultimately, the one thing I have learned through all this is we don't have enough control, enough power on our own to actually make the kind of changes that people in our community need desperately. You've all read about it in the newspaper. We're actually nicer in person than the media sometimes makes us seem. So I'll stop there.
Their sheriff has a foul mouth.
He does. You may have seen that.
Russell.
Good afternoon. My name is Russell Goodman. I live in Northwest Colorado. I'm a member of the Mental Health Colorado Brainwave. I'm a person in long-term recovery from opiate addiction, and I'm the parent of a child with mental illness who received care at Mine Springs.
Thanks. You want to say a bit about your task force involvement?
Sure. I, as a person with lived experience, have the opportunity to participate on the birth of the next generation of mental health care in our community. And part of that is the care coordination user design work group that I'm a part of. One of the emerging themes in mental health as we redefine our system is going to be care coordination, or the notion that we utilize warm handoffs and appropriate transitions to ensure that people don't experience gaps in care or inequitable access to care, and that care is accountable and excellent.
Great. Fantastic. Thank you. Dr. Medlock.
Good evening, everyone. My name is Morgan Metlock. I am a crisis psychiatrist and addiction specialist, also an equity advocate, and I was recently appointed as the Commissioner of the Behavioral Health Administration. Great to be here.
Can you speak for just a really short bit about your divinity background?
Yes. So I am a minister and indeed have trained in divinity. And so, as we spoke in the recent op-ed, bring a lot of faith and science to this role.
Thank you. Dr. Clark.
Thanks. I'm Dr. Carl Clark. I'm the president and CEO of WellPower. We just changed our name from the Mental Health Center of Denver. We found our name was a barrier to some people actually accessing care. I'm really happy to be on this panel because I know everybody here is deeply concerned about access to care. I have the lived experience of having a family member that was quite ill, that did not want help for the longest time, in and out of the hospital for years with bipolar disorder. So I know the anguish there is when you want somebody to try to get help and they don't want to do it. I'm very grateful that there was a system in place. Frankly, I think we were lucky that a system was there, and I don't want it to be based on luck. I've sort of dedicated my career to making sure that people don't have to be lucky to get the care that they need.
Thank you. Lauren Snyder.
I'm Lauren Snyder. I'm the Vice President of Government Affairs at Mental Health Colorado. Mental Health Colorado is a nonprofit, nonpartisan advocacy organization for people who experience a mental health or substance use condition in our state. We do work at a local level, helping local communities try and pass mill levies so that they can help fund mental health services in their communities. We also do some federal work. Our parent organization is Mental Health America, but the majority of our work is at the state level, trying to work at policy, regulatory level, and then as well as trying to change laws to help increase access to care and reduce barriers.
Thanks, Lauren. Ben Marcus.
I'm Ben Marcus. I'm an investigative reporter at Colorado Public Radio. I was between projects when my managers came in and said we want to work with COLab to add some additional reporting to what Susan had found. And my boss, Chuck, had this instinct about the crisis services contract from 2013-14. He felt, and we looked at the coverage had been really thin. And so it gave us an opportunity to do a story we probably wouldn't have done otherwise without Susan's reporting, to look back and see what had actually happened with that program.
And just for context, as we get deeper in the conversation, I want to note that Ben's story really looked at, at that time when they were reforming the crisis care system in Colorado, there have been these, I found in my research, these sort of periods every 5-10 years where some state official and cabinet members announce that there's massive reform happening. And so that was a time when massive reform was touted as happening. And if you can, in 30 seconds, tell us what happened.
So James Holmes walks into the Aurora Theater. He shoots and kills 12 people, injures 70 others. Governor Hickenlooper wants to do something, and so he turns to the Department of Human Services, and they say, by the way, we've been working on crisis services and expansion of crisis services, a plan for the last 2 years. So they just pull it right off the shelf. That goes through the legislative process. They have about $50 million to spend in the first 2 years. An out-of-state contractor gets wind of this. He thinks this is my opportunity to come in and kind of reform crisis mental health services, and then he gets caught up in some of the political power of the existing players and is booted right back out of Colorado again. And so a lot of those details had never been reported before.
Thanks, Ben. Fantastic reporting. Congratulations. So here we are again at one of these benchmark, periods where everybody is talking about, the most sweeping mental health reforms in the 60 years since, the national movement under JFK to deinstitutionalize people and treat them in their communities, thus the name Community Mental Health Centers. If we could start with you, Dr. Medlock, and I think this was a 200 and something page bill. You should know how many pages?
30.
230, but who's counting? That's a big bill. Can you tell us what kind of reforms were just passed? And this was last week at the end of the legislative session for this new cabinet level agency that you will be running called the Behavioral Health Administration.
Absolutely. This is really history-making legislation, and one of the things that really spurred this on is Colorado looked across the national landscape in terms of reforms and found that some states had decided to consolidate all of their behavioral health programs under one agency, but we found through our analysis that that was quite expensive and not necessarily the most effective process. So here in Colorado, we're actually looking at a model of networked government. In other words, a village approach to developing a behavioral health system that's accountable, equitable, and effective. And so the Behavioral Health Administration is really a process of developing formal agreements and networks with all state agencies that touch behavioral health so that we have the same definitions for quality, the same definitions for access to care, that we reimburse and pay for value, that we have a data strategy that focuses on people and their actual ability to access care, that we co-create this administration and its values with people who have lived experience. And I'll stop there and put a plug in for the Advisory Council. So the day after the Behavioral Health Administration bill passed, hopefully everyone knows that our administration released applications for the Lived Experience Council. To me, this is the most critical reform that we are building with and not doing to. Really important for us. So those applications are open until June 11th. I'm hoping that someone with lived experience will join me in co-chairing that council. The other really unique reform is that it also creates and gives me authority as commissioner to convene all cabinet level agencies for the purpose of developing a holistic vision for behavioral health in our state. So we will not only be launching the Advisory Council in July, we'll also be launching the Cabinet Council. And so it's really going to be interesting to develop processes for how those two councils co-create this new administration. We're going to be doing a lot of work in July in terms of our July 1 wins. We're going to be unveiling for the first time a care directory that individuals who need help across our state can access from our new website. It will have geolocation capability. It will be able to show an individual based on what they're experiencing where they can receive help. So we'll have a lot coming out in July, Susan, and we're really excited to launch this new administration.
Thank you. That was succinct, boiling down that many pages to that. Thank you. This is the question of the evening, and I'm going to start with you because we're trying to look forward as much as we can, not backwards. A lot of our reporting has looked backward, and we are at this sort of new age. You launch in about 6 weeks. So what do you need from the people on this panel, individually and the organizations they represent, the kinds of organizations they represent, county commissions, county governments, people with lived experience, community mental health centers, advocates, journalists, to really achieve the kind of reforms you're looking for in a meaningful and concrete way?
Great question. When we think about system reform, it's easy to forget that a system is actually made up of people. And so I think you've heard my framework, Susan, about people, process, and performance in terms of how we build new systems. But the people element is really critical. Within the BHA, we're holding ourselves accountable to a new standard as staff, to daily leading from a place of empathy and integrity. I think the same is needed of all of us on this panel at the county level, lived experience. We all have to make up a new culture in Colorado as people, where we show up, we lead with empathy, we lead with integrity, and it will take that meaningful action together as individuals, recognizing our humanity, recognizing the needs of this state, and being able to work together through meaningful action to build trust.
Great. So I've been focused on not the worried well, meaning people who are functional, living with some mental health challenges. I've been really focused on people who are in crisis or people with serious mental illnesses and conditions and addictions, who, many of whom have been fired from care, so to speak, from the community mental health centers. They're sometimes difficult to deal with. They sometimes don't want help or don't ask for help. They often have several diagnoses, et cetera. Just concretely and very briefly, can you tell me what is going to keep those people from falling through the state safety net under your reforms?
Absolutely. So there's a few places that I'll highlight in the administration, and then I'll share what we're doing internally in terms of our culture. The Behavioral Health Administration bill, first of all, establishes priority populations, which include marginalized populations, and also includes individuals that are experiencing serious mental health challenges, the individuals that you're highlighting. The other thing that the bill does is it provides, in terms of our safety net providers, the requirement that there be a no reject, eject policy. In other words, we don't reject individuals for simply their experience with a mental health challenge or for having a severity of a certain diagnosis, that we lend a helping hand in those moments. A trauma-informed approach asks what happened to you, not what's wrong with you. And we're trying to get rid of this notion of non-compliance with treatment, but rather figuring out missed care opportunities and how can we re-engage those individuals in the safety net.
Really, just in a few sentences, what would happen if a provider who is a safety net provider did refuse care to someone in crisis, safety net care? We're talking about people who are indigent, we're talking about Medicaid recipients. What would happen?
So the Behavioral Health Administration bill requires that I, as Commissioner, work with our Advisory Council, our Lived Experience Council, ombudsman offices across all state agencies, including Division of Insurance and Healthcare Policy and Finance, and the Behavioral Health Ombudsman, to develop a grievance resolution process that is comprehensive and systemic. Now, the date for that is 2024. However, on July 1 of this year, we are releasing our online, phone, and fax, as well as bilingual staff support for any individual who is not receiving the care they deserve. So we have already written a standard operating procedure for how we're going to take those complaints and processes on July 1, and we're hoping to get a head start, even ahead of the 2024 date that is required in this legislation.
So before 2024, if you find that has happened, how long is someone going to have to wait for some sort of remedy to, they're in crisis. How are they, what are you going to do to make sure they get the care they need when they need it?
Absolutely. So for the first time, this administration will actually have a patient-facing, client-facing care coordination office, which is not something we've had. That will sit within our Division of Statewide Programs and Technical Assistance. Now, the funding for those positions is gradual, so we may experience a delay in terms of building up that care coordination office. However, many people have already emailed me personally across the state and hopefully can attest to the fact that even I am responsive as Commissioner when I hear about issues. So we're all filling in the gap in terms of our senior leadership until we can build up this care coordination office.
How many care coordinators will you have on July 1st?
Well, on July 1st, we're hoping to first of all launch the digital product that I just started, that I just talked about. Actually, the soft launch date for that is July 5th, the care directory. That product will talk to our Colorado Crisis Services team that already answers our crisis services line. As you know, in July, there will be another major launch of 988, which is this new program where individuals in crisis can call 988 for help instead of calling for law enforcement for those with mental health crises. So I think, Susan, the answer to your question is that currently our crisis services team, we're increasing staffing on that team, and they are standing in the gap while we staff up internally through our administration.
Thank you. Commissioner Pogue, can you answer the question of what you, as a commissioner, what your community in Summit County, they need from the state, from Mind Springs, which is your local community mental health center, advocates, the media, to realize the kind of reforms you need?
Yeah, I think the first thing we need is some recognition of how bad it is, right? How many people have suffered? How many kids have died? How many people got turned away? Some of those things. You know, I want, if anything, I want people in this state to learn from what my community has experienced, and to take lessons away from that actually create change. I think the second thing we want is choice, right? We want a choice of providers that are held accountable to a standard, that answer their phone, that make appointments, that are there when people are in crisis, so people don't have to go to law enforcement for treatment, because we had to make that decision in Summit County because we didn't have a choice to make any other decision. So really what I want is recognition of the problems, a commitment to reform that is based in some way on what we have experienced, and some choices that really are reflective of the needs of the people in my community.
Got it. I don't want to gloss over your point about how bad it is, and very, very briefly, how bad is it?
So rarely do I get calls from constituents saying, you're doing a great job. That's just not what people do with elected officials. Every time an article runs about what Summit County is doing to help hold Mine Springs accountable, I get 15 calls. And you have my phone, you can play some of these voicemails. But what those people say is, thank you for she does have my phone. I'm very nervous about this. What those folks want is some accountability in the system, because kids are dying, right? People can't get care. And to be told by the state, well, we need Mine Springs, it's a problem for us.
Thanks. Dr. Medlock, what kind of support do you have in place, or will you have in place in July, or as soon as you can, to support local choice and local control?
Well, Commissioner Pogue, is my mic? It sounds like it went out. Anyway, all right, Commissioner Pogue knows that we've met on a monthly basis since I was appointed with the county commissioners, and we're committed to that relationship with our counties. Going forward, actually, Commissioner Pogue and I are meeting next week to talk about how we can support greater access in Summit County, and also how we can improve the mobile crisis response in Summit. So we're on a statewide tour right now. We are with community. We are committed to responding in a meaningful way.
Got it. So when they say we want the state and federal dollars, we want to spend them ourselves, figure out how to spend them ourselves because our system is working better than Mine Springs, is that something that you're willing to allow them to do?
We're going to be talking next week with Commissioner Pogue about solutions to her proposal.
Got it. Dr. Clark. Lauren.
I guess I just wanted to step in and say one of the beautiful things that the BHA bill does that Mental Health Colorado and county commissioners have been advocating for a long time is the ability for a small community-based, community-grown provider to be able to get access to these funding streams that have traditionally only been held for a specific provider type or a community mental health center. We have new provider types called essential safety net providers and comprehensive safety net providers in the BHA bill that will allow small providers that exist in Summit County that couldn't get access to funding to now be relicensed so that they can get access to these sustainable funding streams. And so that's a huge win and something that local communities should know about, local small providers should know about.
Yeah, thank you for saying that. I want to acknowledge there's a lot of buzzwords that go on here. This is a system with its own bureaucracy and its own jargon. What this bill essentially does is break the monopoly that community mental health centers have had for about 60 years in a lot of safety net care. Dr. Clark, from the community mental health center perspective, I'm wondering, how you respond to a desire by a community to want to take things, matters in their own hands.
I think it's great. One of the things that we're really happy about is having a commissioner at the cabinet level. That's never happened in the history of Colorado. Behavioral health has never had the focus that it's needed. And we are in a crisis right now. Prior to the pandemic, 1 in 5 people were dealing with mental health. or a substance use disorder prior to the pandemic. Of those folks that needed help, only 2 out of 5 are receiving help. That's true in Colorado. That's true in the whole country. So this issue of access to care is a serious issue. And if we can bring more providers to provide the care, I am all for that. I'm not concerned about competition. What I am concerned about is, are we just shifting money from one provider to another? That doesn't actually increase access to care.
So you're saying that the capacity doesn't actually expand in changing the sort of procurement model?
It doesn't. You know, some of the advantages, it was the state's decision to contract with community mental health centers, 30, 40 years ago. And the reason is that the pot of money is actually very small. And they passed legislation to designate what a mental health center was so that they could contract directly with the mental health centers, so that there was 17 mental health centers to monitor, not the plethora that likely will happen with the competition. This model that we're putting in place is the same model that North Carolina put in 19 years ago, and it decimated the safety net. It has now been reformed. I hope that we look at that model in North Carolina to make sure that we put safeguards that doesn't create a disaster.
Sorry, go ahead.
Yeah, I would just say that, you know, this model actually is people-focused. It's a model that does require that we go after new funding streams. Certainly, if you only have, you know, one size pie, you can't just cut it in smaller pieces to create more access. Okay, we do have to enlarge the overall funding stream. So our larger strategy is actually to integrate new funding streams. President Biden spoke about this in his State of the Union address, that there will be a national mental health strategy that Colorado is actually aligned with, and from which we will be able to draw new funds to support our safety net.
Is Governor Polis willing to come up with a new funding source, and what is it?
Well, first of all, let me speak to the $500 million that's being poured into our system from ARPA. Now, Susan, in terms of the fiscal cliff that we're all obviously concerned about in terms of 2026, which is the year that those funds have to be spent, we're already preparing for that.
Right,
But
I'm sorry, I just want to tell the audience
Yeah.
who doesn't know what ARPA is. These are
Yeah.
one-time only COVID-related federal funds. I'm actually really asking a different thing. I'm not talking about one-time only federal COVID-related funds. I'm talking about a state revenue source.
Absolutely. So I spoke to the federal mental health strategy. Colorado's actually aligned with that strategy. The comprehensive safety net provider and essential safety net provider definitions that are used in our bill are actually aligned with evidence-based practice. Many of our community mental health centers are actually applying to become what we call certified community behavioral health clinics. This is a national evidence-based strategy. The BHA bill is aligned with that, and the President of the United States has already stated that he's going to bring funding to support that new model.
Thank you. Lauren?
Yeah, I mean, I guess I just want to just clarify that one funding stream that isn't, there's only a certain amount of money for it, is Medicaid. It's an entitlement program, of which the bulk of our behavioral health funding is funded through an entitlement program. So the more need you have, the more access to care you have, actually the more money we pull down from the federal government to pay for that. So I think actually expanding the safety net, getting more people into services will actually drive more funding to come into our system, because more people accessing care means more funding in there. And I think, especially when people have a choice of where they go, the funding that we have currently, our hope is that they will have better outcomes because they're getting the treatment and services that they want, the choice that they want. Local communities can choose which provider they want.
Can I just ask a question? I mean, we've been asking this question in Summit County, how much money follows Summit County in the behavioral health system, and we've not gotten a concrete answer to that. And the answer I get is, it's very complicated. It just seems to me, before we start adding money to the system, and trust me, I am the first one to say there needs to be more money for care, but shouldn't we ought to know what we're already spending first?
I'm glad you mentioned that. I'm going to move on in the spirit of time to Russell. What do you need? to see this system making the kind of reforms that would have been meaningful to you, especially when trying to find help for your daughter?
I'd first and foremost love to see an evolution of the culture in our mental health practitioner community. Not that individuals don't strive for excellence, but I think as a culture, we don't demand excellence. And so long as mediocrity is billable, there's no incentive. And one of the things that we experience in Northwest Colorado, dealing with essentially a monopoly in mental health, is that there's that lack of competitive incentive for excellence. Furthermore, I'd love to see an increase in capacity for care. In my personal story, I was a child of affluence who received very expensive care and was lucky to have done so. I also received care that was publicly accessible that cost nothing. All of those things contributed to my successful outcome. Those things don't exist in my community.
I'm going to interrupt you and just read this quote that you gave me the other day on the phone back to you and everyone, because it really moved me. So he was trying to find help for his daughter, and you can talk about that, please. And you said, and you were really fed up with Mind Springs because they essentially fired her from care. She was too difficult, they said. And so you were left up there with nothing, no other alternatives. And Russell said this, he said, "I thought I was so alone. I actually thought I was a bad person for criticizing these people who are trying so hard." And I think that's a really unique thing that maybe Ben and I also experience, and maybe Lauren as well, is this feeling of, well, hey, we're mental health providers. We're here to help, and they're very sensitive to criticism. But the aloneness that you felt, can you talk about that a little bit, and just trying to get something that would keep your daughter alive?
In my struggle to keep my daughter alive, who I am blessed to say is alive today and thriving, I always looked within to see what I could do better to effectively communicate my needs. And every time my needs failed to be met, I assumed it was because I didn't speak to them clearly enough. And so it was my failing. Unfortunately, my perception of the system at the time was adversarial. It felt like my pursuit of care involved roadblocks that I had to overcome. That began with the first ring of the phone in the Mind Springs office. With the first person who answered that phone, I was beginning an uphill battle to attempt to seek care. I'm blessed with the capacity to communicate. I'm blessed with the capacity to read and comprehend. Not everyone starts with that position. So it's lost on me how phenomenal a failure of equity it is to have a graduate degree to attempt to understand the system that's caring for your child.
Thank you for saying that. Thank you. So you need, you also talked about a door to walk through. Can you just briefly explain what you mean by that?
Sure. There was a time in my life where I knew I was potentially at its end. I felt like I didn't have very much more time in this world and that my death was going to come at my own hand. And it wasn't a debate that I was having with myself, it was a fundamental reckoning with an inevitability. And when that happened, I was with a person who had the wherewithal to take me to a community mental health center in a different state, and there was a door through which I could walk and ask for help. And that's what I did, and they saved my life. And here in my experience in rural Northwest Colorado, I don't think I would have survived that experience because there is no such door through which I could have walked and appeal for help. And I took my appeals for help for my daughter all the way to the top of the food chain, to the director of the Office of Behavioral Health, who was empathetic, but ultimately things didn't change.
Do you think a lot about people who don't take their concerns and grievances up to the top of the food chain? Some people are not able to do that for many reasons.
Absolutely. I feel deeply for people who have to struggle to access care. I feel like there's radical inequity in the system. And when I say inequity, I mean that we're not all starting from the same starting point with resources to request care. Some of us need more help. We need a little bit of a hand up, or we can't access the same kind of resources somebody else might need to be able to access. And those are failings in our community, and they result in deaths. I believe that when you seek care, you should have the opportunity to continue to do so until you die. And that was what I was granted, and that was not the experience I had with my daughter.
Right. So there are communities in our state now that have community mental health centers, but and I'm going to just cite Boulder, for example. They recently, and this was just after the Marshall Fire, which is, arguably the biggest, disaster that's happened to such a broad community in the state. Boulder closed its crisis care. It's sort of night and night weekend hours. So there is not a door to walk through. Is that going to change? I'm going to go back to you, Dr. Medlock, because people have been waiting for you to come for a long time, and people have been waiting for this BHA, Behavioral Health Administration, to launch for a long time. And so I think there's a hope among a lot of people, what's going to be different on the 1st of July? Is that door going to reopen in Boulder? What are you prepared to do about making sure it is?
Well, I have visited the Boulder Center and talked with their leaders about how we can help them get back on their feet. We know that the impact to that community is tremendous as we're in an ongoing mental health crisis. The leaders there have expressed a rational response in terms of the workforce shortage they're dealing with, and we're trying to help them through that. The reality is that we're in a dire workforce shortage, and that is what is driving the closure at that particular center, and we're trying to help them stand back up by July 1. I'll also say that our workforce development officer has been hired and will be onboarding in June, mid-June, and we'll be releasing a workforce development strategy for our state by September 1. But that particular center is dealing with dire workforce shortages, and like I said, we are trying to get them back on their feet by July 1.
Thank you.
So Susan, I would
Please.
just add, it's not just Boulder.
Mm-hmm.
If you look at all the mental health centers in the state, we have over 900 open clinical positions right now.
Right. I understand that. You also mentioned to me when we spoke yesterday that when I asked you about the Community Mental Health Center's record on care coordination, that a lot of it, that you're sort of unfairly judged, these centers, because so many people in crisis don't want care or don't even know that they're sick. Can you speak to that briefly, please?
I don't think that's a crisis issue. When people are in crisis, they do show up. The issue is more, people don't know what to do when they're ill. And this is across the board. It doesn't matter what the socioeconomic, status is. It's like people where do I get help? How do I get help? Can I afford the help? Does my insurance cover the help? And then where do I find it? And then when we talk about the 2 out of 5 that are getting help and the 3 out of 5 that are not, here's the issues. They don't know where to go. That's one, right? The other is that there are some people that are in denial. They kind of know they need help, but they, are not really ready for help. And then there is a symptom of some illnesses called anosognosia, which is the inability to know that you're ill. It's a profound symptom. And so family members run into this all the time. They have somebody they know needs help, but that person's own experience is they don't need help.
I guess my goal with the BHA and with our culture of our behavioral health system is those last two populations you're talking about are the folks that are falling through the cracks the most. They are our homeless populations. They are the people that are languishing in jails, waiting for a bed at mental health center or the mental health institute at Pueblo, and they are the people that need the BHA the most. they are our responsibility. We know who they are. We need to go to them and stop asking them to come to us. And I think that is the fundamental change of our system.
Yeah. So I appreciate that, Lauren, and that's why we have programs like the co-responder program, where we send a licensed social worker out with a police officer. Prior to having that program in place, 97% of those people went to jail. Now 7% go to jail. The others are connected with treatment. We have the STAR program where some 911 calls come directly to us, and we send out a licensed social worker and a paramedic in a van in plain clothes.
Right.
First 2,000 people we saw, no police backup, and people got what they needed. So I agree, the model is changing to where sometimes it's not come see us, let's go see you. We've long had a system where we put clinicians in places where people already go, child care facilities, nursing homes. And you're right, there is a group of people that needs our care, our protection, and our outreach.
Commissioner Pogue, when you hear Dr. Clark's response, what's your reaction?
I mean, I think the question I would ask is, well, why aren't all the CMHCs doing that, right? Because ours doesn't. And I get very uncomfortable with the sort of, oh, it's just Mind Springs mentality, because I frankly hear from folks, commissioners across the state, that it's not. But we're paying for our co-responder program with some help from the state, so thank you for that, because our CMHC wasn't doing it. So where's the accountability to make sure that other centers are making the right decisions like you all are?
Yeah, there are some funding issues. One of my concerns about the BHA is the pot of money that's available for competitive and all of that. It's 44th in the country. And this is information that comes from the Substance Abuse and Mental Health Service Organization. They look at that data and it's like, wow, we're trying to achieve a lot with a very small amount of money, which means then we actually ration care, don't we? We say only for folks that have serious and persistent mental illness and sort of ignore the suffering of other people.
Right. Other panelists, when you hear Dr. Clark say that they're not funded well enough, do you have, is that the case? Is that...
Again, there's a $1 billion in our system. We still don't have an answer about where funding is going. We have many counties that do mill levies. We have 6 different departments outside of just the BHA or HCPF that fund mental health care. That it's trying to understand what is it that doesn't pay well enough for you to set up this type of a program, co-response. I was thinking more of a treatment program instead of co-response with law enforcement of a clinician goes to somebody's house and stays there and goes there frequently and repetitively. But again, Medicaid is a entitlement program, and it's not limited dollars. The more people access it, the more funding we have. We are an expansion state. Colorado is actually above and beyond other states in our nation as far as our Medicaid benefit. We have a full substance use benefit, which is amazing. I think we're well set and well funded to be able to provide these types of services. It's just understanding where funding is going, listening to providers about what parts are underfunded, what parts are maybe we can work on. So, yeah.
So Lauren, I'm with you. I'm so thankful for our Medicaid program. And so as an example, in Denver, and you're talking about other providers, 55% of the Medicaid services in Denver are provided by providers other than the mental health center. We do provide 45% of the care, and what's great about it is that usually folks that are seen by private providers have sort of more straightforward issues that they're dealing with, which means that if they're taking care of those folks, then that gives us the capacity to help people with more complex problems. So private providers aren't often looking at or dealing with this person has a major mental illness and a substance use disorder, they don't have a job, and they don't have a place to live. And the centers really try to do those wraparound services to help that group of people.
Did you
And
wanna say
they're
something?
compensated to do that work.
Yeah.
And they're compensated
That's right.
Got
to
it.
do that work. And in terms of the financial, transparency, we have hired an unconventional CFO to lead the BHA, who's a national consultant who has done behavioral health reform in multiple states, and will be joining our administration July 5th.
Okay.
This CFO will be responsible for ensuring there's transparency in terms of how funds are used, as well as how funds are braided to support a robust safety net system.
Thank you. Commissioner Pogue, did you
Well,
want to
I-
respond to the money question?
I mean, I don't know that there's much more to say about the money. We don't know how much it is. We don't know where it's going. There's clearly more money we can leverage. But, I've spent some time working in healthcare, and the Center for Improving Value in Healthcare can actually tell you how much these things cost and how much people are getting paid. And we don't have that same kind of data in this space, and it seems like that's where this conversation needs to start. But to the care coordination, we have built a network in Summit County of private providers who do care coordination. And it's just, we're paying them to do it,
I hear you.
and it works really well.
Got it. We have had a lot of questions from the audience leading up to this event, and people are sort of perennially interested in the $819,000 that you made a reported earning in 2019. Dr. Clark, I know that that's gone down this year to, I think, $560-something thousand, but with some sort of $600,000 loan on a split dollar kind of life insurance loan that is often offered to the nation's top executives. How do you reconcile the asking for more money, as you and other centers have perennially, when you're making that much money and when people are waiting as long as they are for psychiatric appointments and for care?
So it's a part of living in the United States that we live in a market-driven economy. Anybody here who runs a business knows that the decision on what you pay somebody is actually dependent on what those kind of positions pay. So in our center, we do focus on trying to pay our staff at the 60th percentile, which means that you're paying better than 60% of organizations in that space. And for behavioral health, we're looking at healthcare, not just behavioral health care. What does it cost to pay a nurse and those sorts of things? And so to attract the talent, we want the best talent we can have because these are tough jobs. And so our board does a similar process of looking at my compensation and the compensation of our executive management team. And those are decisions that they do with sort of an independent review about, what it takes to attract talent.
Got it. Anyone want to comment on that before we move on?
I'm actually less concerned about what you make annually. I think what I hear from people with lived experience, especially professionals, because people who are direct care workers are also part of our brainwave, our network of advocates, is why we value them at such a lower rate, especially our peer support professionals who, as you just said, those wraparound services are what makes a community mental health center what they need, what people living with a serious mental health condition need the most. And those are peer-delivered services. They're highly effective, and yet we pay them $12 an hour. Like, where is that? We bill for it. We get reimbursed for it. Why can't we pay our workers a livable wage, especially when they are have the most effective outcomes for our most vulnerable people?
So, Lauren, I agree with you on that, and it's why in December, when we were looking at the 60th percentile, there are certain positions that you cannot live in Denver at the 60th percentile. So we initiated what we call our living wage. So no one in our system makes less than $50,000, including our peer mentors.
Except for the part-time people.
Say again?
Except for the part-time people, and there are many.
The part-time people, yeah, I mean, if you were a peer mentor and you worked half-time, yes, you don't make $50,000 a year.
There are people in your organization who want to be working full-time and are
We
not.
have, I probably would disagree with you on that one, because we have open positions right now. We have 93 open clinical positions. Anybody who wants a full-time job can get it.
Okay, so you're not ever capping the amount of someone's work because.
No, we don't do that.
Okay, good, thank you. Please.
I have an anecdote that may apply.
Yeah.
One night with my daughter, in my community where I live in Steamboat Springs, we have 0 mental health beds in the county. So if you experience a life-threatening mental health crisis, you are put in an ICU bed and you're observed by an ICU nurse, which could be argued is a misallocation of resources. That said, one such evening, after shepherding my daughter through a crisis that almost took her life, we ended up in one of those ICU beds in the hospital, and we were visited by a crisis interventionist. And that crisis interventionist was a very empathetic individual. And I'd like to think we made some progress that night. We cried, we hugged, we somehow survived that evening. And then the next morning I had to go to work. And so I knew I wasn't going to make it through a day of work without a coffee. So after leaving the hospital, I went to our local drive-through coffee place, and the woman who handed me the coffee through the window was the crisis interventionist from the night before. So I feel like those positions should be well enough funded that a person could do that and not have to have a second job in a coffee shop.
Thank you, Russell. Lauren, what do you need?
Oh, we're skipping to me. Okay.
Well, I feel like Dr. Clark said what he needed, which is more money. So I feel like we just went through that.
Okay.
Yeah.
I think we need to have a realization that we need each other, that we can't do it. We got into this mess kind of all together. We all have a part to play in why this system isn't working appropriately. Advocates, community leaders, providers, state level folks, all of us. So I think we need each other. You know, I think it's been a very contentious past few years and we hit a kind of critical junction this winter and this session. And I think moving forward, we need to work together. And I think kind of what Commissioner Pogue said, I think we need to people are wanting to have an honest conversation about what's not working. And to be open and honest with that, transparent with that, and then say, okay, how do we move forward? What do we need? And at the center of that, we need to be listening to people who experience the system above and beyond anyone else. You know, they are experts by their experience. They are more well-versed in the system than any of us, period. Because they've been through it. They've lost loved ones to it. They have almost lost their own lives to it. And if we're not listening to them, then we're failing yet again. And I think we need to realize where we have failed, where the system was immovable, and realize and just say, we're moving it, okay? We're changing the system now, and we're gonna change it based on what the people who use it say, not based on what is most beneficial or easiest or whatnot for other folks. So I think, you know, for Commissioner Pogue, I need more of you. I need more people, more local leaders that believe in behavioral health, that advocate for it, that talk to their constituents about it. Russell, we need more brave people like you to say how the system failed you. And I need, Commissioner Medlock, you need to listen to him and to say, yes, we failed. And this is how we're going to change it to make sure no other family goes through what you went through. We need more well powers. We need more providers in every part of the state. We need media to hold us accountable. And unfortunately, we need more advocates. We need more people saying and advocating and talking about mental health, talking about stigma in their workplace, in their schools, to their parents, kids. You need to say, talk about mental health, talk about substance use to your families. That's how we change things.
I'm so glad you mentioned that. I'm a new observer of this system, and for the last year, I've sort of noticed the centers have come to see some advocates as enemies, or people at the state as enemies, or people who are in the news media as enemies. I've noticed there are people who are in the state and I'm not including you, Dr. Medlock, who certainly come to see lawmakers or members of the media, that there is a real sort of fractioned, territorial culture that goes on around mental health policy in Colorado. And how are we going to get what Lauren is wishing for, this sort of, coalescing of all of these special interests?
Well, trust is broken in this state across all lines. And as I was describing to a colleague, this entire system in Colorado feels extremely traumatized to me. And I think the only way we move forward is, first, the BHA has to make meaningful action. It has to do what it says it's going to do, and that's my job as the Chief Vision Officer. I think we've also got to engage in radical communication. That's what we're trying to do with the Advisory Council. We're trying to make sure that the voices of people who have lived it, people who I have served as a psychiatrist. I mean, I could tell you stories from Washington, D.C. that would shock you. I mean, people entered my office in handcuffs. That's the type of work that we did, but they left free. I mean, that's the kind of work that I think we've all got to center around. I believe every person on this panel cares about people. And so our blueprint is putting people first. I think the only way we get through this massive trauma that has happened in Colorado is through meaningful action, meaningful communication, and I'm committed to seeing that through, and I need the other partners here that are represented to join me in that work.
Thank you. Some people wonder, and I had this in the questions today as well, is the trauma due in some part or more, do you think, to the structure of the current system? Some people suggest the trauma has to do with certain people in certain power positions who are just extremely territorial. And this sort of bifurcation of the system where you have HICPUF, and again, I'm trying not to use jargon, but HICPUF is not, in fact, like a puppet of John Hickenlooper. It's the state agency that manages and disseminates Medicaid funding in the state. You have HICPUF controlling most of the safety net purse strings, right? But then, we've always had Office of Behavioral Health, or for many years, Office of Behavioral Health. Now we'll have the BHA doing this sort of policy piece. And I certainly, and I want to get to you, Ben, on what you need, but I think the media, I think advocates, I think county commissioners have all experienced, I know community mental health centers have experienced this, and people with lived experience, this sort of ask your mother, ask your father. We don't do windows. One agency will send you to the other agency saying, well, they're responsible for that. That's not our domain. How are you going to, you did talk about this advisory, your cabinet, but how are you going to break that culture of, this is my sandbox, not your sandbox?
Well, the same thing that we have been doing with our community in terms of the state tour, I did the same process with our cabinet. It's about relationships. That's how we're going to get through this. So our cabinet tour has resulted in us having weekly contact with healthcare policy and finance. We're working together on a joint fiscal management system so that we can track funds that move through the system, irrespective of how it's paid for, whether Medicaid or through Behavioral Health Administration funds, so that we can be accountable to the people of the state. We're also working with HICPUF on universal contracting provisions, so that irrespective of which agency is administering behavioral health services, we can hold them accountable in terms of quality metrics and access to care. So I actually have found that healthcare policy and finance has come to the table. We plan to have formal agreements in place with what we're calling the health cabinet. So out of all agencies, there's the health cabinet that's made up of HICPUF, CDPHE, Division of Insurance and Human Services. Those formal agreements will actually be in place on July 1 first. Then we're going to exercise formal agreements with all state agencies that touch behavioral health.
Got it. Thank you. Ben, you've been so quiet over there. What do you need, Ben?
Well,
We're here to help
I'm in a unique
you.
role because I'm not an advocate. I don't run a center. I'm not in government. And so my problems are actually kind of stretch across any agency, but it was particularly acute in looking at behavioral health care, as there are massive gaps in the historical record. And so you're trying to reform a system when it's not clear what happened in the past. In 2009, before the Rocky Mountain News shut down, there were about 500 journalists between those two papers. Today, there's 65 at the Denver Post. And now some news organizations have come in and backfilled with some journalists here and some journalists there. But we were starting to see massive layoffs in 2014 and 15, and that's when the coverage we were looking at, the development of the crisis mental health care system, there just wasn't follow-up coverage. And so like the director of human services at the time, Reggie Bika, could say, well, we settled this case, but that was not exactly true. And nobody really reported that out, that the state hadn't actually settled this, that the centers had paid this out-of-state contractor to go away and drop his lawsuit. And then half of the stories I've done since I've become an investigative reporter, I'm finding have settlement agreements which have non-disclosure clauses attached to them, which means we have no idea how much was spent, what the terms of the deal were. Nobody can talk about it. Nobody can do interviews about it on microphone. And so we're just kind of left with, in our case, luckily there were hearings, court hearings, where we could go and we could listen to testimony about how Mind Springs was doing in Summit County, about the efforts to apply political pressure to make this out-of-state contractor go away. Email retention. So not only do you have fewer journalists in Colorado watching state government and industry, but you have state government keeping fewer records. So I haven't worked everywhere, but of all the states I've worked in the United States, Colorado may be the worst at open records in that every agency has a different retention schedule. They're often a matter of months now before they're deleting emails. Some cities and counties are at 4 and 5 years. I've been working at CPR for almost 12 years now, and I've never deleted an email. So it's hard to make an argument that there's some cost thing. So Governor Hickenlooper was the governor at the time of the crisis expansion. So when we asked for emails from his administration, you have to go through the state archivist. And Hickenlooper's representatives can review your request before you get emails from the state archivist about what happened then. So there are so many barriers in place.
You mean Polis's?
No, you have to go through Hickenlooper's representatives.
Because it's the Hickenlooper administration's
even though he's not governor
archive.
Anymore,
Hear you, sorry.
They get final say on the emails that are released through the state archivist, which was shocking to us. So not only do you have not enough people covering it at the time, but being able to go back and try to figure out what happened is extremely difficult.
I'm going to just pile on top of that and just say, because the community mental health centers are private nonprofits, even though they get most of their funding from taxpayers, we can't, when I asked you, Dr. Clark, the other day, how much did you spend on a rebranding effort recently, renaming Mental Health Center of Denver Well Power? What's the answer?
It's the same answer I told you before.
Yeah, I'm just asking you to say it.
So, yeah, it's a one-time investment in trying to improve access to care for our community. And it is a part of business. It's a part of any business. What I can tell you, 0 state dollars were spent on the rebrand.
Okay, but can you tell me how much?
And I can tell you that 0 public dollars were spent on the rebrand.
Can you just say how much?
No.
No. And so this is a frustration I'm just sort of trying to illustrate that the media runs into. I'm sorry to pick on you. But any response to that? I mean, about transparency. I know you've had, Commissioner Pogue, serious transparency challenges in finding out, as you've said, how much money is being spent on mental health care, state and federal money in your own community, and you can't get answers to that. What can be done about this?
Well, Susan, one of the reasons why I'm here tonight is because this is a new day in Colorado, right? We have been, so far, with very limited staff. We don't even have our full leadership team. But I met with you, Susan, before my boxes were unpacked in my apartment.
You
Remember
did.
that?
Yes, I did. Thank you.
And so we are extremely committed to transparency. The real issue that I need the people of this state to understand is that any delays that you experience after our launch are simply due to us that needing to hire folks, all right? Once we bring on our team and build our administration, I do believe you will feel the impact. This is truly a new day, and we are committed to being transparent, and that's part of why I'm here tonight.
Okay, thank you for the answer and for being here. And I'm going to jump to audience questions, which are trickling in from our live audience. I'm getting texts and all sorts of questions, so I'm going to try to squeeze some of them together. But one is for Dr. Clark. This is from the audience. What is your organization doing to reform policies that exclude people experiencing homelessness, such as discharging people who miss their appointments?
So first of all, that doesn't happen. We treat, and I would say all mental health centers, treat everybody who comes and consents to treatment. So this is a part of healthcare. If you go for a surgery, you consent to have the surgeon do their work, or a cardiologist, or whatever it is. And that's true in Colorado too, in behavioral health. When somebody comes, you disclose what your credentials are, and you have them consent to treatment. Now here's where the rub is. There's a lot of people, and Lauren, you were talking about them, right? Is that they don't want to consent to treatment. Maybe they don't even know that they're ill. And so we do a lot of engagement activities to try to engage folks. One of them is getting people housing. You know, so our Sanderson apartments, we got 60 people that had been homeless for more than 10 years off the streets. That kind of relationship building is a way to engage folks that are hard to engage. That being said, those kind of services are not billable and they're not paid for.
Do you think it's the role of a safety net provider to accept people into treatment who may not even want it? There are things called a mental health involuntary certification where you can, by a court process, force somebody to get treatment if they are a danger to themselves or others or gravely disabled. Do you think that that's the role of a safety net provider to accept those people who are our most vulnerable individuals?
I do, Lauren. And so right now across the state, there are 450 people that the mental health centers are serving that are court-ordered to treatment. So this is what happens in our world right now. You have somebody who doesn't want to consent to treatment, and they're very ill, and the court determines that they are a danger to themselves or other, or they're so ill a bad outcome is going to happen, like they're going to die on the streets because they can't take care of themselves. So that's a process that the courts take very seriously, because when you take somebody's right away from them to make decisions about their own body, it's a big deal. It's a big deal. So our center in particular, our average is about 150 people that are on certifications at different times. And so I do believe that's a part of the safety net. But it's that other group that we have to come up with more creative solutions. What do we do with that group that people have experienced that they need help? Everybody knows they need help. Either they don't know they need help or they don't want help. What do we do to put a system in place to get those folks what they need?
I'm going to move on. Sarah Morales from the digital audience. I'm going to direct this to you, Dr. Medlock. In order to secure support for sustained funding, it would be necessary to address the stigma of mental illness and mental health. Are there planned initiatives to address stigma and cultivate compassion?
Absolutely, and I know Sarah. We are right now engaging in our strategic planning process to prepare for the launch. Actually, this week we hosted our strategic planning with our prevention team, and we are looking at how we integrate prevention, promotion within every aspect of the continuum as we move forward. So absolutely addressing stigma, addressing risk factors in terms of engagement with behavioral health system, et cetera, promoting the resilience of families who are supporting loved ones with mental health challenges. All of that will be part of our prevention strategy. The BHA bill actually creates something called the Prevention Collaborative, and we're working with the Department of Public Health and Environment to ensure that that collaborative is powerful and effective in terms of the initiative Sarah is bringing up.
Got it. I'm curious because Dr. Clark, they just renamed Mental Health Center of Denver, Wellpower. I'm sorry, I'm I'm confusing my names, Mind Springs and Wellpower. I wonder, you had said, Dr. Clark, publicly that having the words mental health in your name, and you said it actually, I think, in a staff meeting earlier today, that it was dissuading people from coming in and getting help at your center. And so I'm curious about that. How does that jibe with all these accounts that we get from people who say they can't get an appointment at your center? Number one. And number two, I guess I would ask Russell, would a center renaming itself, Mental Health Center of Denver to Wellpower, make a difference? Because you had said this will, change lives among Denverites or among users. If that kind of name change happened with your community mental health center, would that make a difference in your life?
I can only say anecdotally that my life was saved by a place called South County Mental Health.
Okay. Well, that's a fact. Got it. Thank you.
Didn't stop me from walking in the door.
Mind Springs wasn't Mind Springs.
Yeah.
I'm actually forgetting what the name was. It was something mental health in it.
Right, Colorado West.
Thank you. Yes, forgotten that. But nothing changed when the name changed.
Got it. I wonder, actually, because you're saying the name mental health, the word mental health sort of turned people off, but isn't there a sort of stigmatizing of the word mental health of the term mental health by getting rid of it?
So there has been a long history of, behaviors, ideas, a whole host of things that lead to mental health being stigmatized. And the question is, who takes the mantle on to address that? Do we ask people who are getting services to take that on? Or do we ask providers and community advocates to take that on? And I think that's really more what it's about. So the situation where you have somebody, we're talking and I say, hey, I got to stop now. I have an appointment at the Mental Health Center of Denver. What do people think? I think, Susan, you said that somebody's in therapy, but a lot of people think, what's wrong with you that you're going to a mental health center? Versus, I have an appointment at Wellpower. Wellpower, what's that? It's where I go to improve my well-being. We do think that makes it easier access for folks. Do we still have to address stigma? Absolutely. It's been around for a long time and it's not going away anytime soon.
Thank you. Another question. I'm going to read one from the audience again. When will we have long-term residential services for those with an SMI?
Serious mental illness.
Serious mental illness.
I can answer that.
Yes.
So actually this year with ARPA dollars, so American Rescue Plan dollars from COVID dollars, basically federal COVID dollars, there's roughly $60 million going towards developing 125 long-term residential mental health treatment beds that are going to be available statewide. So it was a huge win. It was something that Mental Health Colorado fiercely advocated for. The middle is missing. We don't have that level of care really throughout the state. And so I think actually CDHS is going to be the Department of Human Services is going to be standing those up, but they are coming and they will be online hopefully by 2025.
Got it. Thank you. I'm going to direct this to anyone who, I'm going to direct this, to you, Dr. Medlock. The question is, this is from Facebook Messenger, will there ever be a day when a state audit of our safety net system actually finds something wrong?
Well, the first issue that we have is we have to develop metrics that are associated with how well people are actually doing. And our strategy in Colorado is to onboard a new data leader that can help us get in line with best practices in terms of an accountable system of care. So our current findings are related to a system that needs to be realigned with patient-centered outcomes and metrics. And I do believe we will get there. And once we select those new metrics, I do believe that our accountability process will be meaningful. Accountability, however, doesn't start with an audit, it starts with a strategy. And our strategy is to first develop accountability metrics that actually make sense in terms of the difference that people are experiencing in care, and then aligning those metrics with how we move dollars through the system. That's what you hear healthcare policy and finance talking about when they talk about value-based payments. So it starts with the strategy. Audits kind of are the result of something going wrong, but we want to first start with a proactive strategy.
I mean, kind of riffing off the news from last week when results of an audit of Mine Springs were revealed that didn't find things that whistleblowers have been saying for a while about Mine Springs. I mean, do you have a concern that whoever's regulating the system beyond metrics, that they're looking hard enough, that they're asking the right questions, that they're talking to people, not just looking at a bunch of data?
Well, absolutely, but that is the responsibility that I have to ensure that we're hiring the right people,
okay,
right, who have the spirit to do this work. I think you astutely said after our first press conference, Susan, that a lot of what we've put into the letter of the law now determines the culture that we're building within the BHA, that is really what comes to life. And we are even now processing our new values, and one of those are empathy, the other is transparency. And we're holding our staff to that going forward.
Thank you. We have 4 minutes for more audience questions. I'm going to try to... Oh, Wendy Wardhofer, who I know, is asking, in what ways can the broader community be part of the solution?
Join the advisory council.
Oh, you really need some advisory council members.
Join the advisory council, absolutely. We have 20 seats on the main council. And then in addition, we will have regional subcommittees from across the state with 5 members each. So please join the council. The applications are open until June 11th.
Great, thank you.
I would say talk about it. Talk about behavioral health. Talk about stigma. Talk about what's happening in your life and how you're feeling. I mean, in Summit County, all of the changes we implemented started with us attacking stigma head on and being willing as a community to talk about the fact that people were actually suffering and struggling, and that ultimately the best safety net you can have is taking care of one another.
Thanks for saying that.
I would ask that the community never forget that we do recover, and that with access to high quality care, we do recover, and we can free ourselves from the soft bigotry of low expectations by assuming that we can implement an excellent healthcare system that will save lives.
Thank you for saying that. Will you just tell us briefly what's going on with your daughter lately?
She's thriving. She travels the world. She does adventurous things that are so far outside my comfort zone. I couldn't imagine how a person gets the fortitude to do them. But she leads her life, and she does so with sound mental hygiene, and that's all I'm grateful for.
I'd love to hear that. Thank you so much. Dr. Clark.
So during the pandemic, I think the us-them disappeared. The pandemic hit the well-being of everybody, and people have a different understanding of this can happen to me. And I think asking for what you deserve, many health plans do not have adequate networks. People have trouble finding care, and when people need and deserve care, they should demand it.
Lauren.
I would be remiss if I didn't get to use this platform to talk about a bill that just passed. So I would say our community should vote. There are elections happening this fall. This Democratic-controlled legislature voted to felonize people who are in possession of substances, predominantly fentanyl, but any substance that has fentanyl in it. People with substance use disorders are not criminals. They deserve care. And I think our community needs to rise up and hold people accountable for sending our folks to jail instead of treatment.
Yeah.
I'm going to give you 10 more seconds to, if you could give us one word to describe that fentanyl bill, what would it be?
A disaster? I don't know.
A disaster. Ben Marcus, it's so seldom that journalists get to sort of have the last word.
Again, I have a unique role here, but I would say that if you get a call from an investigative reporter to not be so adversarial, I think that there's, and this is not just true of behavioral health, but in many stories we cover, there's a sensitivity about criticism and tough questions that shuts down the dialogue and actually makes the story maybe not framed in the way that the advocates would hope for, whomever you're reporting on. It actually has a negative effect. So it's not helping people to not talk. And we see this at state government, and we see this in private industry as well. In fact, when we were reporting out the mental health center story, the Jefferson Center said that there seemed to be an intent to harm through our reporting. And that surprised me. And it kind of shuts down the dialogue right there. Is we're not trying to harm anyone. We're just trying to ask some critical questions about what happened. And yeah, we're not trying to advocate one point of view or another. And I think they feel like we come in with one and that's it. But if you can't talk to us, it's certainly not going to change anything.
Thank you so much for saying that. Would you sort of bend your head toward the audience and let them see that you don't have any green horns?
No horns.
Yeah. Thank you. I really appreciate that. I hope that's heard among the people that reporters ask questions of. We come in peace. Yeah, I really hope your words are heard far and wide. So we have only a couple minutes left. I just wanted to really thank you all for being here on this couch and facing some tough questions and speaking your truths. I mean, this is sticky, sticky stuff. It's deeply personal. People have high emotions around all of this. And so, you know, all of you really contribute to, I think, this new age that Dr. Medlock is describing. And, you know, I hope we can sit here in 2024 and 2026 and look back on this and really say, yes, it's a different system. No, people aren't falling through these cracks. I think that's so important. Just in closing, I wanted to, again, thank you. I wanted to thank the audience here who, in this studio, this new studio that we're thrilled to have you here in person. So thank you for coming. Thank you for your questions. Thank you out there in virtual Colorado, throughout the state. People are listening to this and have been submitting questions for several days now. I really appreciate your thoughts. I want to encourage everyone to follow COLab Partners' continued coverage of On Edge and the mental health safety net system, and encourage them to continue the conversation on social media with the hashtag On Edge. I want to thank CPR for being, Ben's employer, for being part of this. And I really hope we can continue this conversation, and I hope we can all be part of it being truly a new day. So thank you all. And I think the cream puffs disappeared somehow. I don't know what happened to the cream puffs. Oh, there they are. But I hope you eat them now. So thanks, everyone, and good night.